Good morning, everybody. Thank you so much for coming to this session. This session is about pediatric type 2 diabetes, rising incidence and intervention. I am Monica Bianco. I'm a pediatric endocrinologist at Lurie Children's Hospital in Chicago, and one of the co-chairs for the pediatric type 2 registry that we have started with the type 1 diabetes exchange. So I'm very honored to be here and very excited to hear our talks today from our various presenters. We will jump right in to our very first talk, which will be presented by Dr. Mann, who is here from the University of Wisconsin, so not far from me. And she will be talking about reducing wait times in pediatric diabetes clinic by optimizing access to diabetes device data. So we'll have her come up. Okay, so those of you who are just here to hear about type 2 diabetes, note that this is not a type 2 specific talk, and I apologize about that, but I assure you it will be worthwhile. Like Dr. Bianco said, I'm from the University of Wisconsin. I'm a pediatric endocrinologist there, and I'm presenting on a project that we took on this last year to improve our clinical efficiency. So any of you who work in a clinical setting, hopefully you could take something from this that applies to your own practice. And I have to point out here, I have a couple of co-authors and sponsors here on the slide with me. So Rachel and Whitney are two of our coordinators through the collaborative. This work would not have been possible without them. And Courtney listed here is our clinic manager. And so this is just a shout out to those of you like getting started in quality improvement and trying to make changes in clinic. Engage your stakeholders. So Courtney is our clinic nurse manager, and she oversees the nurses in our clinic, but really has a greater role in affecting change. And she was really influential in getting this work accomplished. So shout out to them. So this work started years ago. I mean, even as a fellow, years before this, I recognized that diabetes clinic appointments take a very long time. Some of that is really important, right? Like diabetes is a complex disease, and we have to acknowledge that. And for type 1 and type 2 diabetes, there are a lot of components of our clinic visits. That includes having learners, because we are an academic medical center, so we have students and residents and fellows, and it's very important to be teaching the next generations about diabetes care. So that's obviously a critical part. We also have multidisciplinary care, and we're resourced enough that we have dietitians in clinic and we have nurses in clinic. But what we found was over the years, this sort of expanded to adding more to our diabetes clinic visits. And I think that probably resonates with folks that when we're making interventions, we're often talking about adding things. And so this is really a quality improvement project around really streamlining and, quite frankly, eliminating things, but primarily waste. So that was our goal. That's kind of the overarching goal here. So back in 2022, we kind of looked at some of our baseline data, and I was hearing from other docs who were nervous that I was going to start this work. Well, what about learners, and what about when we have nutrition? And so I just stratified the data, just a simple bar chart here, just to show okay, if we look at our average visits, you can see that MD visits were a little longer than NPs. If there's a learner, it takes longer. If the patient is seeing nutrition, it takes longer. But you can see the average is about 74 minutes. And that was true for type 1 and type 2 diabetes. And those on my team said, it's always been this way. It'll always be this way, which for me in quality improvement means it's time to change. So at that time, back in 2022, and with the help of Rachel Fensky, we implemented a questionnaire. It's on paper. It still is on paper because we don't have resources at UW to turn non-validated tools into Epic patient-reported questionnaires. So we have to still do this on paper and then manually enter it. But I'll show you later how we kind of moved that work from being a synchronous process to sort of an asynchronous process. But we implemented that and achieved a new baseline of 63 minutes. So by kind of eliminating the step of asking patients these questions and entering, and what's on this form, this was a different project we presented years ago, but What was on this form was kind of a lot of the patient-reported outcomes that we're reporting for U.S. News and World Report, but also just for clinical care and for the collaborative. Okay, so in addition to knowing clinic visits were still long, I became the medical director of our clinic about a year ago and started looking more at our Press Ganey patient experience data. And there were a lot of comments about how our visits are too long. Perhaps if you look at your own patient experience comments, you might see something similar. Maybe not, but you can just read through some of these comments. My appointments always take a solid 90 minutes. And this was really key. I feel like I have to repeat the info to 3 different people. Very long wait times, meaning this comment was about wait times once they arrive in the clinic, not wait for the appointment to be scheduled. Sitting in the exam room while waiting for 30 minutes is uncomfortable. 2 hours for a visit is a long time. So you can just see these comments that, really added up. Ooh, excuse me. So this is our key driver diagram. I will call out a few things here, but specifically I'm going to go through the PDSA cycles next of like, what did we do to tackle this problem? But you can see how our PDSA, we sort of mapped our PDSA cycles here to our key drivers. In part, I did this just to guide my clinical team and sort of provide some explanation to kind of support that change management. I'll get to the specifics of that in a second, but you can see we felt like our key drivers were really around diabetes data. So that ended up being one of the most critical things we did was really focus on the CGM and pump and glucometer data and getting all of that efficiently entered into HealthLink, which is our EHR. We use Epic in Madison, but call it HealthLink because it sounds fancy. We also felt like really optimizing that face-to-face time was really the piece that our patients were commenting on. Like there was a lot of downtime between people in the room. So again, that was another way to sort of like get buy-in from our clinical team that we weren't really, none of these interventions were around reducing the amount of time that any care team member spent with the patient, more reducing the time between those care team members going in. And then eliminating repetition, again, that came straight from the patient comments. And then we wanted to be continuously incorporating patient feedback. So I'll hopefully get to how we did that in the next couple of slides. So really the format of these next couple of slides, and I hope that QR code is big enough to scan from where you're sitting. If not, I'm happy to share it or you can look it up. But I really find these change concepts from the improvement guide by Langley and others to be a really useful tool when you're looking at a complex problem and trying to brainstorm like, how do we tackle this problem? Ori presented earlier today, like often we have good ideas of how to fix problems. But I think using a standardized tool to look at, okay, how could I approach this problem differently is good for our clinical teams, our improvement teams to really think outside the box and come up with solutions that maybe we wouldn't have otherwise. So the way these are organized, the change concept on top is literally taken right from that worksheet of change concepts within the improvement guide. So the first 2 PDSA cycles were really around improving our workflow. Specifically, now so much of our diabetes data is in the cloud. And I think some of this idea came from those of us sitting in clinic, waiting for the data to be in our hands so we could go into the patient room, knowing that data was there last night. I could have seen the data this morning. So kind of recognizing we had some work to do to get that data entered into the EHR. And probably some of you use modern tools that upload data automatically. We don't have those tools. We enter a lot of our CGM data and other in a flow sheet within Epic, and it takes time. And we were sitting and waiting. So some of the methods we used, this is also from the change concepts there, but we found and removed bottlenecks. We worked on ways to do tasks in parallel, so not waiting for one task to be completed and then moving to the next one. The next PDSA cycle was really around modifying the clinic flow. So specifically what we did, you can see the old to new there, is we switched up the order in which we were going in the room. We had been having our nurses go in and obtain data. We had been doing things that way for about, I think, 20, 30 years. And we really shook it up. And this was with Courtney's help to say, no, really, the provider should be going in first, and then subsequent services can be utilized when needs are identified. And here's where the meat is. I really like the X bar S chart. So you're seeing mean visit duration for 2-week periods here on the left side. And you can see that right when we started these changes, we had a significant improvement in or reduction in our visit length. And then we've been incorporating patient feedback using Press Ganey surveys, but also just getting feedback from families. We had some cool process measures. We used a dietetics intern to sit outside workrooms and literally just tally how long a patient was by themselves in the room. And so we did that, just some pre-post data, just to get a sense that, yeah, we were reducing that wait time, so that downtime between providers going to the room, which was pretty cool. And then the balancing measures really were around patient experience. Do patients still feel like they're getting what they need? And some of that, isn't just in watching glycemic outcomes, making sure that we're not eliminating essential parts of the visit or education. Some more work to be done there. And here's a picture of my team. Here's my clinic nurse manager on the left there, Courtney. Huge shout out to her, because getting people to change their behaviors in clinic is really hard to do. And I couldn't have done it without her. And here's my team on the right. All right, now I'll take any questions. Yeah, go ahead. Sheeta, I want to go first. Yeah. Great question. We've iterated on that quite a bit. So now we have a care coordination assistant. So she's a non-clinical person, so not an MA. She does a lot of work for us on like prior authorization and paperwork and that kind of stuff. So she's very familiar with all the portals. So she downloads or like gets those reports, and then either her or one of the nurses will enter that data just the morning of clinic. So kind of when they arrive, they open like clinical info notes. And as long as it's the same day, we recognize that it didn't change how things were viewable in our flow sheets for during the visit. So it's a combination of our CCA and our nurses. Ideally, I feel like it's a great role, and I've heard others kind of speak on like MAs. We just don't have we have a lot of MA gaps, and so our MAs are stretched thin. Yeah, Risa. Yeah, yeah, yeah. Great question. So the first question, and I'll repeat for those maybe listening virtually, was where did the data come from? And I feel like I asked my analyst, like, how can I measure this? Like what? And there was a reported outcome that he's been able to pull from Epic, that's visit duration. There are definitely, it's not perfect, right? And so it doesn't always, like I did some sampling to kind of assess, like, does that seem similar to what we were looking at or what we were experiencing in clinic? And the answer is yeah, most of the time. I think there are some times where the visit duration is like 600 minutes. That's happened like 2 or 3 times a year. That clearly there's something wrong with that data point. So we've decided to just remove that one. So because it's a quality improvement study, we measured it the same over time so that we did see a change. Now, exactly, is our average visit length now 63 minutes, down to 50? I don't know what our actual experience is, but we know that we've seen an improvement in a measure that we can get easily, if that answers that question. So, not perfect data. And then your other question was, oh, why? Yeah. Yeah. So then the other question was about like why the order change of nurse going in first, followed by provider versus provider going in first, change the visit duration. And I think some of it is that our nurses are not supported as or not required to be CDCESs. So our nurses have a lot of diabetes experience, though it's variable, and the specific roles and tasks for them is not clearly defined. They do provide some education, but they end up kind of going when the nurses were going in first, they were obtaining the diabetes history in their own way with patients who's not their primary patients. They don't necessarily know the patients. They're kind of getting to know the patient, obtaining history, maybe providing some education, but really we're kind of functioning more as like data gatherers. Though I think the perception was that they were providing education, but I think in that role going in first, they were really data gatherers. And then the provider would go in, repeat some of the same questions because it's very hard to share out every detail of a 30-minute conversation in a sign out. And part of it is just the sign out from one person to the next was taking a long time. And I think we've all had these experiences with families where you go in, ask questions, and realize, oh, actually, I can address most of what they're talking about. There's not really a lot of additional need. And then they can go if they're done, right? So now we've kind of shifted to say the provider can go in, assess needs, take the history. You're the one who knows the family best, and then identify if there are targeted education needs. So I think some of it is reduced redundancy. And then I think the other is actually allowing the nurses, opening up the nurses to be in a position where they can provide targeted education. I'm sorry I couldn't get to more questions. I think we're out of time, but we can chat after. Thanks.
Thank you so much, Dr. Mann. That was very, very interesting. But in the interest of time, we will be moving forward. If you do have questions, please, that we were unable to get to, please find Dr. Mann afterwards. All right. Our next presentation is by our very own Ori Odugbesan, and she will be talking about low continuous glucose monitoring use in youth with type 2 diabetes. This is baseline data from the Type 1D Exchange Pediatric Type 2 Registry. Thank you.
Thank you, Monica. So I'll be talking about CGM use in type 2 diabetes. And this is my favorite slide. The reason I like the slide is because, the collaborative has grown so big. I started when we're just 10 centers. Now it's 63 across 23 states. So that's why I like the slide. The incidence of type 2 diabetes in adolescents and young adults is increasing. Compared with people with type 1 diabetes and compared with adults with type 2 diabetes, this group experiences more rapid disease progression and a higher rate of developing complications. Despite this risk, adolescents and youth with type 2 diabetes have limited access to advanced diabetes management tools such as CGM, which are widely used in type 1 diabetes. CGM is beneficial to glycemic control in youth with type 1 diabetes and with adults with type 2 diabetes. However, there are limited studies to show the importance of CGM in type 2 pediatrics population. American Diabetes Association recommends that CGM be offered to all youths with type 2 diabetes that are on insulin therapy. For methodology, like Monica said, we established the Type 2 Pediatrics Registry at T1D Exchange. The T1D faculty at the 25 centers identified core outcomes, including CGM that will be benchmarking. 15 of the centers provided baseline CGM data for 2024, and 6 centers shared monthly CGM data with us via the Smartsheet from September 2023 to July of 2025. So this is the demographic table. It's a lot of information, but the point of this is that we asked centers to share this data with us. So they shared the total number of patients they are seeing every year. Of that number, those on public insurance, and then they shared the racial and ethnicity, the race and ethnicity for the patient, and CGM use was also part of what we had asked them to share. So we looked at this data, and this is the result from that data that I shared. And you can see that there's marked variation for CGMUs across the 15 centers that shared the CGM data. And you can see that more than half of the centers that reported have less than 50% CGM use. This indicates that there's differences in prescription and access to CGM. Center 12 has 1% CGM use, and Center 11 has 50%. Center 10 has 50% CGM use. And some centers were also sharing data monthly. So amongst the centers that were participating, 6 centers were sharing monthly data from September of 2023. And we looked at the aggregate data for the 6 centers, and we saw that the median CGM use is 22%. And this demonstrates low baseline CGM adoption in this group. This is low, as you can see, compared to type 1 diabetes and the rest of the type 2 population. One of the limitations of our study is that our analysis was based on baseline and aggregate data reported by only participating centers. And then we didn't really look at CGM use amongst those using insulin alone. In conclusion, baseline data from participating centers demonstrates low CGM use among adolescents and youth with type 2. And given the rising prevalence of type 2 diabetes in this population, there's a need to increase CGM use in this population to improve glycemic outcome and reduce morbidities. Acknowledgement, we're grateful to the co-chairs of the Pediatric Type 2 Committee. It's such an engaging committee and we're thankful. We also want to thank all the faculty that participates in the monthly meetings with this group, and we're grateful to the MZ Charitable Fund for supporting the collaborative. Are there any questions?
So I'm wondering that the data that looked at all of the centers with type 2, so of that type 2, then there's a lower percentage of those who are on insulin, which is why, and part of it is why that number is so low. But is there work, and maybe for the group at large, is there work going around getting those patients with type 2 who are not on insulin on CGM? So I think one of our biggest challenges is insurance adoption of that. Not because we don't want to, but it's getting it.
Yeah, I totally agree with you. And I think it was with Jessica, we still had a conversation during our last check-in that, it's tough to prescribe CGM for them due to insurance. And when we were asking for this data, we didn't really ask about pump use. So it was just like, who is on CGM? Let's just even see who's on CGM amongst the whole group. So thank you. Go ahead, Dr. Jenny.
It's more like CGM or like young adults or
No, we didn't. Like, that's another, limitation, because right now we just wanted to start and just get data that we have, and the centers are not mapped yet, so they're not on the portal, and we didn't want to burden the centers, to report too many data. So we just wanted like 5 key data elements. So we didn't, we didn't ask for that. But there's a lot more that we can do with that group. So, any other question? All right, thank you.
Thank you so much for that. Yes, there's still a lot of work to do and a lot of data to collect, but we are working as hard as we can to get everyone kind of onboarded, and hopefully we'll have more data to share in the future. So next up, we have Dr. Guarneri. And she will be presenting on assessing health literacy in pediatric type 2 diabetes. And she comes from the Children's Hospital in Pittsburgh. All right,
Good morning, everyone. My name is Alissa Guarneri. I'm a pediatric endocrinologist at UPMC Children's Hospital of Pittsburgh. This morning, I'll be discussing our quality improvement project on assessing health literacy in pediatric type 2 diabetes. And this great work was done as part of a collaboration of a multidisciplinary team. Pediatric type 2 diabetes, as we know, is a very complex disease with increasing prevalence. And despite treatment advancements, the overall quality of care remains suboptimal. And one of the most important factors contributing to this is health literacy. Health literacy is defined as a person's ability to obtain, process, and understand health information. And we know from adult studies that low health literacy directly influences poor self-management behaviors, low treatment adherence, and poor glycemic control. In pediatrics, that extends to not only the patient, but also their caregiver. And low health literacy is linked to low technology adoption, as well as increased risk of complications. And recent studies have shown that as much as 8% of caregivers of pediatric diabetes patients have low health literacy. Now, the American Diabetes Association recommends using validated, age-appropriate health literacy tools in pediatric diabetes patients, but unfortunately, no diabetes-specific instrument exists, and thus our project was created. So here at Children's Hospital Pittsburgh, we manage approximately 140 patients with type 2 diabetes. We average approximately 20 new diagnoses each year. Average age at diagnosis is between 12 and 13 years, and most of these patients have an elevated BMI. The average hemoglobin A1C at diagnosis is just over 9%. We also face challenges with social determinants of health, and where up to half of our patients identify as non-white or non-Caucasian. Most of them are publicly insured. Some of them have no insurance, and we have a no-show or cancel rate approaching 30%. When looking at the location of education at diagnosis, patients who present with a hemoglobin A1C of less than 8.5%, as you can see in the bar chart on the left, most of them receive outpatient education. And this is in pretty stark contrast to our patients who are diagnosed with an A1C at or above 8.5%, who are primarily admitted for inpatient education, and 100% of whom are started on insulin. And so to better understand our patient population's health literacy, our team did a deep dive at the literature to assess which validated health literacy tools existed and quickly realized that there are none. And so our multidisciplinary team sat down and we created a brief, less than 10 question survey that was aimed at not only our youth with type 2 diabetes, but also their caregivers. This survey assessed understanding of diagnosis, treatment, complication monitoring, and factors that impact blood glucose. We had a goal to gain input from 15% of our total patient population. And so for our first PDSA cycle, we targeted administration of the survey to patients seen within our main children's hospital clinic. We were able to receive 17 patient and 14 caregiver surveys, or just over 12% of our patient population. And so in order to get closer to our initial goal in PDSA2, we expanded that administration to our satellite clinics, and where we were able to reach that goal of 15% of our patient population. And so things that we learned from the survey responses were that nearly 90% of patients and 100% of caregivers reported either very good or some understanding of type 2 diabetes. But despite this, nearly 20% of patients and 22% of caregivers were either unsure of the recommended frequency of office visits or reported office visits that should occur every 6 to 12 months. We also learned through Pareto analysis that both patients and caregivers demonstrated a unique and limited awareness of complication monitoring for pediatric type 2 diabetes. In the patient population, this acknowledgement was limited to hemoglobin A1C, weight management, and blood pressure control. In contrast, caregivers demonstrated a broader awareness of complications needing to be monitored, which does suggest a better understanding of the long-term systemic complications associated with type 2 diabetes. Both patients and caregivers demonstrated in alignment relatively the factors that improve diabetes control. And so primarily those being physical activity, blood glucose monitoring, and medication adherence. But despite this, upwards of 20% of patients and their caregivers either answered incorrectly or were unsure of which factors should be monitored long-term. And lastly, unfortunately, less than 100% of both patients and caregivers demonstrated awareness or recognition that things such as sweet treats or carbohydrates could affect blood glucose. Taking those key learnings from the surveys, we acknowledged that despite there being self-reports of generally good understanding of type 2 diabetes, there are clear discrepancies between patient and caregiver perception of knowledge and actual knowledge. And so this led us to the development of our SMART aim, which was to identify gaps in health literacy among our patients with type 2 diabetes within our clinic and improve those factors that can impact health literacy by 10% from baseline by June of next year. So our team sat down and really wanted to create a depiction of the very complex interconnection of factors that can impact type 2 diabetes. And what we found was that health literacy plays a central role in this, in not only the management of type 2 diabetes, but also on the quality of life of these patients and their families. And so we created a fishbone diagram to really understand and look at which factors can really impact that low health literacy. And we identified things such as socioeconomic factors, education gaps, cultural differences, etc. And identifying these factors really helped us to fine-tune our interventions and helped us to target our future PDSA cycles. So in creating our key driver diagram, we established that our overall global aim was to improve the quality of life of our pediatric patients. But keeping in mind our SMART aim, we were able to identify specific key drivers that can impact health literacy in youth with type 2 diabetes, including assessment of health literacy, education, efficient use of technology, patient and caregiver engagement, and staff training. And we created interventions tailored to each key driver. And you can see with the color coding legend to the right, the status of each of those interventions. And so we still have much work to be done. Our current PDSA cycle, we decided to focus on standardizing the education delivered to patients. And so we started by shadowing in our wellness clinic. Our wellness clinic manages many of our patients with prediabetes or are currently being evaluated for type 2 diabetes. And so often this is the first touch point for counseling for these patients. And key learnings that we took away from that included that generally, the information that was relayed to patients was very reasonable, very appropriate, but the depth of that knowledge and that counseling had very wide variation from patient to patient. These visits focused on setting very simple, tangible goals, and the language is generally kept very simple, which was very helpful and patients were receptive to. The latter part of this cycle, we are planning on shadowing and observing in the outpatient and inpatient education for new onset type 2 diabetes patients, primarily to assess key differences in that education. And so we look forward to learning those things. So through this very early work of this project, there were several key learnings that we had. First, that health literacy plays a critical role in successful management of pediatric type 2 diabetes, and there are clear gaps that exist, particularly regarding key monitoring metrics and nutrition. Age-appropriate targeted education for not only patients but their caregivers is warranted to optimize management and quality of life. And perhaps most importantly, there's a significant need for a validated health literacy survey in the pediatric type 2 diabetes population. Thank you for your time. Happy to take any questions.
Was it on paper? Was it a QR code? How did you administer that?
It was on paper. Yes. It's a wonderful question. Just English, although language barrier is on our list of potential interventions to try and improve the education provided to families. But yes, English. Yes.
Great talk in a very clearly much needed area. So thank you for that. One quick question I had is, when do you assess for health literacy? And is it just at one time point, or do you do it repeatedly?
So assessing for health literacy is novel within our type 2 population. For the purposes of this project, we decided to target patients who have had a diagnosis of type 2 diabetes for at least 2 years. And that is mostly to understand retention, and then through our key drivers and interventions, potentially targeting all the way back to diagnosis, how we can impact health literacy later on. Thank you.
I had a question about maybe your survey, or if you could just speak to this broadly, the difference between health literacy versus like disease-specific education, because I sort of think of those things sort of separately, and I wonder how that came up in creating your survey, how that played in.
We wanted to start broad, and so I think when we defined health literacy, we really wanted to understand what is the general understanding and knowledge of our patients for their disease, what are the subsequent comorbidities that have been developed, so sort of the entire process. And so when we developed this survey to assess their literacy, we really were looking at what can we do to improve their knowledge and their retention so that ultimately we're decreasing their comorbidities later in life. I'm not sure if that answers your question. Sorry.
Yeah, it does. Can I ask a follow-up question?
No, please.
And I think I saw on your fishbone, like one of the items, I think of health literacy, like, do you know where and how to get your prescriptions? Like if you need a refill, what steps do you take? Like kind of the general, like how does the healthcare system work? Like what is an appeal? What is your health insurance? What's a copay? What's like those things? I'm curious, these are topics we've been thinking about educating in our general, like our whole diabetes population. I'm curious if those are aspects that you've addressed, or is it mostly like, again, disease-specific education?
It's mostly disease-specific education. Your point is very well taken. We haven't even broached that, but there's surely room for improvement there.
Oh, we have a question on Zoom.
Sure.
From Trudy. So was there any assessment of level of education or capacity to do math or better model education efforts?
There was for the caregivers. We did assess education level. I didn't include that data in the slides, but we did not assess ability to do math, but we did assess their education level. So we do have that data.
I'm curious if you were able to see if there was any link whether the parents themselves had diabetes.
Oh, that's a wonderful question. No, we didn't even look at that, but potentially for future iterations, yes. because you would think the education delivered to adults is likely different to pediatrics, but maybe not. Thank you.
Thank you so much for that. That was very wonderful and definitely a topic that is much needed. And I do think that this is something where our efforts could definitely come together because we're all facing these challenges about educating our patient population. So sharing what we learn is very, very important. Next, we have our next presenter, Dr. Culbreth from Texas Children's Hospital or Baylor, I'm not sure, both. And she will be talking about step-by-step increasing physical activity in youth with diabetes.
Good morning, everyone. Just a disclaimer, I am not a physician. I am actually a PA. So just Lauren, but I'm also an exercise physiologist. And so I have a little bit of a unique perspective working with patients with diabetes on definitely a goal to get people physically active. So today we're going to talk about one of our initiatives to do that. So I don't need to go on and on about the benefits of diabetes with all of you experts in the room. I'll save my background slide for something different. So we all know the ADA standards of care. The goal is for every patient to be getting 60 minutes of moderate to vigorous aerobic physical activity every single day and at least 3 days per week of muscle and bone strengthening activity. But why did only 1 in 5 patients actually achieve that goal? And so this was a study I just wanted to highlight that was done in Quebec. And disclaimer, my presentation is not just on type 2 diabetes as well, just like Dr. Mann said. So this was done in Quebec. They surveyed 200 patients with type 1 diabetes for at least 3 months of duration. They asked their parents and the children with diabetes to rank some of these barriers. So you'll see 12 barriers were listed there, and they had them rank them from 1 to 7, with 1 being extremely unlikely to be a barrier to exercising and 7 being extremely likely. And you'll see that they differentiated by age category, so less than 12 and greater than or equal to 12, but in both there's a common thread. Fear of hypoglycemia is a really significant barrier, especially for our patients with type 1 diabetes. And while we can't control work schedule or the fact that it's like 25 degrees outside here in Atlanta today, what we can do is provide better educational materials and support to help empower our families to live a physically active lifestyle and, overall improve their A1C, glycemic control, BMI, all the things. There also was an interesting finding here that greater parental support overall led to lower overall perceived barriers. So the rankings were overall much lower when their parents were encouraging or engaging in physical activity with them. And so this education doesn't just need to be provided to the patients themselves, but to the parents, because these are going to be the biggest determinants between our clinic visits when we're spending just a few minutes with them. So this is our team. I'm Lauren, and Millie Beccaria and Grace Kim are also here. You probably all know them very well. And we work together on the following SMART aim, which was to increase the percentage of youth within our clinic with both type 1 and type 2 that were being assessed and meeting goal of at least 10 to 30 minutes of moderate intensity physical exercise at least 3 days per week by 5% by the end of the fiscal year. And so these look really small on here. I'm sorry if it's hard to read, but we used a few QI tools to get started, one of which was a fishbone diagram. So on the left, we listed in black barriers to our patients meeting the ADA standards of care, and on the right in green, we listed possible interventions to overcome them. And so from a process point of view, we identified that our educational materials were kind of outdated. Now in the age of closed loop systems, we really needed to update some of those. From a patient and staff point of view, medical school, PA school, all the schools really give us the educational material to say, we should provide lifestyle modifications. You should get 60 minutes of exercise, but they don't really equip us with how exactly do we educate our patients and families on how to put that into place. And so we needed to provide education throughout the multidisciplinary team to help us feel more empowered to do that. From an equipment point of view, whatever interventions we made had to be equitable. Not everybody has access to technology, exercise facilities, equipment, and so we needed to keep that in mind. And last but not least, from a measurement point of view, We had no standardization of measurement. This was being measured by providers, dietitians, diabetes educators, and so we needed to streamline that process a little bit. So we took our fishbone diagram, placed some of the interventions onto a key driver, prioritized them on our effort impact matrix, and then implemented them through our rolling action item list. And I'll talk a little bit more about each of the PDSA cycles we use next. And so first and foremost, we had to get our documentation standardized so we could actually track our data. And so our dietitians and diabetes educators were already using something called goal documentation, and we wanted to just already use what was in place and not reinvent the wheel. So what we did is we added in a goal that said we'll accumulate 10 to 30 minutes of moderate intensity exercise at least 3 days per week. And at the assessment that the dietitian or the diabetes educator was already going in to do, they talked with them about this goal and were able to track, are they meeting this goal 50% of the time, less than 25%, et cetera. You'll see that on track is crossed out there. We previously just said they were on track or not, but we needed to kind of delineate that a little bit further. And then secondarily, in May of 2024, we educated our dietitians on the physiology of exercise and diabetes and provided some management strategies that would be practical and useful for them to use during their assessments. This is one of my most favorite things, is that we actually integrated exercise prescriptions in June of 2024. So the American College of Sports Medicine is the accrediting body for exercise physiologists, and they have something called Exercise as Medicine. The idea behind this is that you would prescribe exercise just like you would prescribe a statin for hypercholesterolemia. And so this is broken down into aerobic and muscle strengthening exercise. So we use something called the FIT principle in exercise physiology, breaking down exercise into frequency, intensity, time, and type. The idea is that a provider will spend 1 to 2 minutes during their clinic visit discussing this with the patient. This is patient-led. They're the ones that are going to be expressing it. You're not going to just tell them, I prescribe you 20 minutes of bicycle. So they spend just a couple of minutes discussing with them. This is a smart phrase that is put into the after visit summary for those Epic users. And so this is printed out when they leave clinic. They have a physical copy, and this is something that can be followed up on at subsequent clinic visits for them to see how exactly are they doing meeting that goal. Another thing I'd like to highlight on the bottom is the what's your why. And so really we want to identify what exactly is that motivation for this patient. And this, again, is patient-driven, so whether or not they want to improve their glycemic control, BMI, blood pressure, cholesterol, these are all things that they can discuss. And so we educated our providers on this initiative and asked them to start implementing this into their daily practice with especially type 2 patients, but overall any diabetes patients. In September 2024, we began doing some community outreach. And so on the bottom left, that was our 2024 booth. I also included our 2025 booth just for fun. And I think our costumes were a little bit more organized. We were all Astros players this year. So we do a diabetes bash every year at Texas Children's Hospital. It's a community gathering where we give out candy and have costumes and just gather people in the diabetes community. And so to kind of counteract that candy, we wanted to have a physical activity booth where what we do is we have the child engage in a fun activity such as like a jump and reach, a wall sit, doing some wall push-ups while we're discussing with the parents about some educational material. So we have handouts there available. We're there all with some clinical expertise, and we're answering questions and just providing them some guidance as needed. And we've had a really good success with that as well. In October 2024, we continue to educate members of our team. So our diabetes educators got some education on advanced exercise management strategies. This was especially surrounding closed loop pumps with all the different activity mode, exercise mode, et cetera. And then in November of 2024, we implemented patient-facing educational materials. So they're a little bit small, I apologize, but in the bottom left, this is our new AID and exercise handout. So it's stratified. The colors kind of delineate the intensity of the exercise. So we've got on the top left corner, aerobic light intensity for a minimal amount of time, so like less than 60 minutes, where you would have like a 25% mealtime bolus reduction or utilization of activity mode. And then the more intense or the more prolonged it gets, the strategies change just a little bit. And for the sake of time, I won't go into more detail. On the right, we implemented a full body workout in 10 minutes handout. So this was more geared towards our type 2 population, but for anybody who is looking to get started with exercise. It requires no equipment. It has a 1 minute warm up, a 1 minute cool down, and then 8 minutes of exercise from a circuit that you do twice. And so the patient can scan the QR code. It takes them to a playlist of all of the videos showing them how to do the exercise. Again, requires no equipment, very beginner level, and kind of addresses some of those barriers and gaps that some of our patients might be experiencing. And then in February 2025, we did a webinar with some of our families on how to manage diabetes and physical activity just to gain a wider audience, and distributed these educational materials amongst them. And so here's our results. So you'll see our baseline was in Q4 of 2023, and we were able to assess 21 patients during that quarter. This is our baseline, and 38% of those patients were actually meeting our goal, which was 10 to 30 minutes of moderate intensity physical activity at least 3 days per week. By the end of Q2 in 2025, actually 73% of our patients, which 408 patients were assessed then, were meeting that goal. So not only did we get better at assessing, but actually more of our patients were meeting the goal too. So overall, we thought this was really successful, and we're excited about the next steps to come. That's all I've got. I'm happy to take any questions.
Hi, Jessica from Alabama. We recently stumbled on the goals in EPIC, and we're all quite excited about that. Excuse me. In our prediabetes clinic, we've been using the goal setting and documenting the SMART goal. And what we've been doing is scheduling a message to the patient 2 weeks after the visit on the day of the visit, pulling in the SMART goal that they documented and just saying, following up to check in on how you're doing. And so we've gotten some nice feedback for that between visit contact with literally 1 click from the provider because we saved it as a quick action. And so just something to consider if you're doing that. It's nice to have touch points with patients with no effort. Makes them.
I love that idea. Thank you for sharing that.
Hi, this is Emily from Cornell, New York. Also, don't say you're just a PA. That's phenomenal stuff.
Thank you.
Real quick, it'd be great to see if we could see more of the handouts you gave. And I just want to go back to the prescription you sent. So is that a true prescription, or is it really just like a thing that you put in the after visit summary?
Yeah, it's not a real prescription. This is an after visit summary SMART phrase, but it's meant to look like a prescription because it's kind of cute. And I think it just adds some gravity.
I think it made it like official, like, right? Like,
Yeah.
you talk about lifestyle modifications all the time, but then this makes it like, no, this is part of your plan. So I really liked it. Thanks.
Thank you.
Thanks, Lauren. This is Andrew from Cleveland Clinic Children's. Great presentation. I love the materials and actually would love to steal some if that's an option, both with the prescription as well as the exercise charts. Exactly. The question relating to those, for those of us that are in different parts of the country, you guys probably deal with 2 hot days. We deal with a lot of 2 cold days, and really trying to figure out what activities can be done. Do you have a list of like tips or tricks or different things, especially from a virtual world standpoint, how we can get our kids up and moving? Thanks.
I do have a list of apps and YouTube channels that I would be happy to share. I have to just get permission to make sure that we can share these because they're branded, but I would be more than happy to share them. But yes, I like, just off the top of my head, Cosmic Kids Yoga is a great YouTube channel if you guys haven't heard of it. They have like all levels of activity that, you know, it's really easy to do, very engaging for the kids. I'll also say that for patients who are just looking to do something, I'll often tell them to put on like a virtual walk. And if you can't get outside to walk, you can walk inside your house, and you can do walks through national parks. I mean, there's everything on YouTube. So just like a really easy, low-hanging fruit. Perfect. Okay.
It was a great presentation. I really enjoyed it. We're looking at exercise at our institution as well. But my question is, when you're putting it in goals, and I don't know how technical this is, but like, are you guys able to retrieve that information through like a data pool electronically from goals or not?
Yes. Yeah.
Okay.
It's all done. We are not doing this manually.
Perfect. Great. That's awesome.
Yeah, we recommend it. And I'll make a last plug if I finished a little bit early. What I would really ideally like to do, and I would encourage each of you to consider doing if you didn't have as much red tape as I do at a big institution, is to actually consider objective fitness assessments in your program. And so Angelina Bernier at the University of Florida has a great online resource where she talks about how to do this. And that's where I did some of my training. So I would really encourage it. It's our big picture goal. But if you have an institution where you can do that, it'd be great.
Are there any questions from online?
Not at this moment.
Okay.
But we do have a question for Dr. Mann from your previous presentation that we weren't able to get to at the time from one of our Zoom attendees. So it's also from Trudy Murray. So did you break down by provider at all to see if some providers might have workflows that others could learn from if they were leading the visit order and organization for the day?
I love that question. And I think that's a great tool to use. And we definitely did do that. So there's a term for that that I am blanking on, but where you break down data, basically like it's not a performance metric, but you break down data by provider and you present that provider with the data and then just in a curious way. So we definitely did do that. And there were a lot of trends we could find. So we did a lot of stratification of the data and just evaluating based on different to kind of develop our different ideas. So we definitely did do that. And we found we had some people sort of piloting going in first, and we found like the provider going in first, and we saw early success with that. So it really was kind of like, and I summarized this, it didn't put it in all the detail, but it was something we definitely started very small and then expanded the workflow.
Thank you, everybody, for attending this session. It was a great session. I think we all learned a lot. And of course, we all know that there are many things that we need to do to improve the care of our patients with diabetes, type 1 or type 2. And that is something that we're really looking forward to continuing to do, and definitely with the focus on type 2 diabetes as we move forward. And hopefully, if you have any questions or anything for any of our speakers, they're here in the room. So please feel free to come up to them and ask them a question. And if you are interested in type 2 diabetes and your center has not joined our pediatric type 2 diabetes registry, please reach out to Ori, Nicole, me, Monica Bianco, or Tammy Hannon from Indiana. We're the ones who are making sure that we're getting this work done and getting the data for our patients so that we can improve their care. Thank you.